that are novel for that purpose to predict outcomes. And predict outcomes means either hard outcomes such as death or MI, but also could mean outcome for changes of function or events that otherwise could have been clinically relevant. Markers that are continuously tested for this purpose. The strain has recently become a very interesting one. It is now more and more easy to measure strain using MR reliably, and that could be the strain itself, which is the deformation of the tissue, but it could also mean simplified indicators of strain, such as just the longitude, the length of the anatomical long axis of the heart. And these two markers are the purpose of the studies that we present today. So we'll start, and I stopped sharing my screen. We start now with Magnus Carlsson, who I welcome cordially to this journal club, who will present from Sweden, who will present their paper called the Ventricular Shortening is an
Thank you so much. And
a predictor of death in ejection. People die with normal ejection fraction still, and a lot of those with abnormal ejection fraction still have events, still do not have events and have their ICD basically implanted for no good reason, you could argue. So Magnus, I'm very much looking forward to your presentation. Go ahead.
Thank you so much for inviting me here today. Our paper was recently accepted in Scientific Reports and published in October. And as you heard the title, just briefly here, I've just highlighted that our purpose was to see if longitudinal shortening in the way of AV plane displacement, or MAPSA, and global longitudinal strain measured with CMR are independent predictors of cardiovascular and all-cause death, also in the patients with HFrEF, so patients with ejection fraction below 40%. And we included 287 patients, and over a 5-year period, there were 40 cardiovascular and 60 all-cause deaths. And we found in the, skipping here to the main results, that both mean AVPD and global longitudinal strains were independent predictors of all-cause death, with a hazard ratio of 1.24 per millimeter decrease, or for strain 1.15 per percent decrease. So let's go down now to the more nitty-gritty details of the paper. So what is atrioventricular plane displacement, and what is global longitudinal strain? So I will jump down to the methods, which is in the end of a paper in this format. So this is a standard 4-chamber Cine with end diastole to the left and end systole to the right. And we did measure the MAPSA, or AV plane displacement, from diastole to systole using an automated algorithm in the Segment software program that's freely available to everybody in research, and did the measurement by that automated program. In the same Segment software, we measured strain by delineating the endocardial epicardial contours in diastole, and then using the software to propagate the contour over the cardiac cycle, and got a global longitudinal strain measure. So you can see here that the difference between the two measures is that strain measures what happens in the myocardium, so the global effect of in longitudinal shortening. And the MAPSA, or the AVPD, or TAPSA in the right ventricle, it measures how much the effect of this contraction is on the atrioventricular plane. And remember that the atrioventricular plane is directly facing the atria, so the amount of movement here in systole will result in how much the atria is filling during systole. So in this case, by having a longitudinal shortening of this plane, the ventricle will automatically load itself for the next contraction by aspirating blood into the atria. And strain then is a more myocardial measure. So that can be some of the explanations between the differences seen with these measures. So we can go back now to the introduction. So we had know from earlier studies that both of these measures are reduced in patients with heart failure. We also know that they both are predictors for MACE and all-cause mortality in different categories. For example, in outpatients referred for CMR, or in patients with an EF below 50%. That's been studied before. What we wanted to see is that in this specific group where it's actually below 40% ejection fraction, is there any remaining prognostic information in the longitudinal shortening? I was thinking when we started this that would be hard to prove. That I thought that there would, when we come down to very low ejection fractions, that there would not be any room left for prognostic power. But it turned out that that was the case. There is actually room for more prognostic information in these patients with very low ejection fractions. Also, when it comes to measuring MAPSA, in the earlier studies were done by Iqwal, and now some studies are using the lateral point and some studies the septal points to measure MAPSA or AVPD. And some studies, for example, from Johns Hopkins, have done a normalization of AVPD to cardiac length, creating sort of a sort of strain measure or shortening measure. But it's unknown if this prognostic value of MAPSA or AVPD is influenced by the location of the measurement. So we wanted to compare the different measurement points to see if there were any rationale for doing multiple points, or if one point is enough. So we included 295 patients who had an ejection fraction of below 40%. And because of some bad image quality, we only had 287 patients for analysis. And if we look at the patient population, they were in total, had an age of 62 years, and more than half, 59%, had ischemic cardiomyopathy. They were mostly, half of them were in NIA class 3, so they were quite sick. A vast majority had optimal medical treatment at the time, with 92% beta blockers, 90% RAS antagonists. Half of them needed spironolactone. And this was before some of the newer therapies for heart failure were introduced. So at that time, this was optimal medical therapy. Their kidney function was actually not so bad. And they, of course, had increased NT-proBNP. LGE was found in the vast majority, 77% of patients. And we can return then to this table a little bit after. We did a follow-up on registry in Sweden. The registries are very comprehensive, and they cover all mortality causes, and they also cover all hospitalizations in all hospitals over the country with ICD codes. So we could do look at how many had died over the full follow-up, which was in median 7.9 years. But we choose to analyze primarily the first 5 years. Why 5 years? We're thinking that after too many years go by, other factors than sort of your original status of your heart will be more important. And things like in this patient group, cancer and other diseases will play a role. So we opted for a 5-year, but we also presented the appendix, the full follow-up as well. During the first 5 years, we had 40 cardiovascular deaths and 60 all-cause deaths, as I said before. And this is showing ventricular function versus NIA class. On the left, we have AVPD or MAPSA. In the middle, we have GLS, and on the right, we have ejection fraction. And we can see that with worsening NIA class, the measures decrease, both for all three measures. But it's a little bit stronger relationship with AVPD, but generally the same story here, that with worsening function is also worsening symptoms. This is the Kaplan-Meier curve for cardiovascular death in the same way, AVPD to the left, in the middle GLS, and to the right ejection fraction. And you can see that when it comes to tertiles that we divided them in, it happens to be over 30% is the upper tertile. So over 30%, there were actually quite good outcomes. And also for AVPD, there were a bit, with the statistics here, a bit better separation with AVPD compared to the other two measures of function for cardiovascular death, as well as for total death or all-cause death. There is, of course, higher mortality rates if you include all causes for mortality. And then ejection fraction doesn't become as important when you include other causes for death, such as cancer or fatalities for accidents, etc. I'll skip the univariate predictors and jump right into the multivariate model here. So we studied AVPD and GLS in two separate models because there was a very high correlation between GLS and AVPD. So then it would be very hard to interpret AVPD and GLS in the same model. So for cardiovascular death here, we see that in the model where you add AVPD or MAPSA, there is a significant increase in prognostic power and the likelihood ratio test with a mean AVPD and the multivariate of 1.33 per millimeter, meaning that there is 30% increased risk of cardiovascular death for 1 millimeter of decrease of AVPD. And that's over age and sex, etiology of ischemic cardiomyopathy, LGE presence and ejection fraction and volume, left ventricular volume. For GLS, that was not significant in the same way when it comes to cardiovascular death. But if you look at all-cause death, then GLS was significantly associated with outcome. So in this way, what we can say is that AVPD seems in this population to be a better correlation with outcome compared to GLS, which may be a bit surprising if they now have a very good correlation, right? But I think what we are thinking is the reason for this is that the AVPD is quite easy to measure. It's quite reproducible. GLS have more user, you need to do the delineation of the ventricle, and it's a bit more affected by image quality. A MAPSA you can always measure. So that's one speculation we have why there is a better statistical correlation here with prognosis with MAPSA compared to AVPD, or compared to GLS. Here is the slide showing the different in hazard ratio compared to where you measure. In short, we can say that some have looked at lateral measures, some have looked at septal measures. In our study, the septal measures were a bit better compared to the lateral measures of AVPD, but the best measure was actually, with using the mean of all points. And that makes sense that you will take away some measurement variability if you use a mean of the 6 points. So that was the paper, and I'm open to hear any questions.
Thank you very much, Magnus, and I hope my internet connection is now better. I think this is very interesting, and especially because it would allow to assess a different marker than just ejection fraction, but from the same images, basically, at least the AVPD. The question I have is, and I encourage everybody, if there are questions, just type them in the chat, and we will address them. So the AVPD, which is basically, you mentioned also the term MAPSA, so in echo it has been used, just the motion of the valvular plane. Isn't that subject to whether you correctly angulate your slice to the valve plane? So I could imagine that if you angulate it slightly differently, then the measured difference may actually change even disproportionately. So do you think that is a problem?
Yes, it is. I mean, if you would not collect your images perpendicular to the left ventricular true axis or the AV plane, then yes, it will be a problem. Yeah, I think that's correct. Yeah. I also think that would be correct for strain.
Yeah, and then maybe at the same time, so if one other issue I thought about is that if you take the displacement of the valve, then it may be that the apex actually either moves a lot or does not move at all. So the total shortening of the long axis of the left ventricle could be measured on one end, but assuming sort of that the other end is kind of stable. But if it is not, and we know that in really healthy hearts, there's also shortening happening at the apex. So wouldn't it make sense to just use the long axis shortening, just the shortening of the long axis as defined by the apex and the mitral valve plane?
The problem with that is that if you have a foreshortening, as you call it in echo, or if you're not cutting through the apex correctly, there will be a big difference, and there will not be a true motion. It's just that you're outside of the apex in systole and inside in diastole. So that affects the measurements much more. So you don't gain so much by that. When we measure the apical motion, when we have the true apex in sight, there is just a millimeter or so of motion. There is very little motion if there is not a lot of pericardial effusion. As you get pericardial effusion and the pericardial function is lost, then you get a lot of motion. So in those cases, it doesn't work.
Okay, no, thank you. So quickly before we move on, two questions from with short answers from the audience. Javad, do you think that APVD is a marker for atrial function or more for LV function, or both?
I think it's the combined. It's a combined. It's both atrial and ventricular function. I think that's why it's a better prognostic value, but that's a speculation.
Okay. Okay, thank you. And then next one, given the prevalence of functional mitral regurgitation secondary to the etiology of the LV systolic dysfunction, was there an interaction of mitral regurg and AVPD, and was AVPD less useful in patients with significant secondary mitral regurgitation?
That's a great question. And we did exclude patients with more than mild MR. So it's not in the paper, I know, but that's, we could want to have the impact of valvular regurgitation as well, but that's a great question.
Okay, yeah, and then the last question, thanks for the short answers, by the way, Magnus. So did you measure AVPD and GLS on just the 4-chamber view, or did you take an average of 4-chamber, 3-chamber, 2-chamber views?
The average of the 3.
Okay, okay, great. Thank you so much, Marcus, for presenting this very interesting paper. So we'll move on to the next, and I welcome, so if you unshare your screen, and I welcome Nigel Tan from the Division of Cardiology at Terence Donnelly Heart Center at St. Mike's Hospital in Toronto, with a group of Andrew Yan, who's also joining. Thanks for joining. Nigel will present his paper published in the Journal of Cardiovascular Magnetic Resonance, and it's titled Myocardial Strain Assessment Using Cardiovascular MRI in Recipients of Implantable Cardioverter Defibrillators. So Nigel, take it from here.
Thanks for the introduction, Matthias. Can everybody hear me okay?
Yes, sounds great to me.
Okay, terrific. So I'm just sharing the screen here. Hopefully you guys can all see the PDF. So
can you zoom in a little bit?
Yes, for sure.
That would help for those with smaller screens.
Try to
Thanks.
Like this is better?
Yeah, great. Thank you.
Okay, terrific. So so the topic that we published on was myocardial strain assessment using CMRI in recipients of ICD patients. And I think, as you suggested, I'll just walk through the PDF, which kind of covers the salient features. So my background, as most of you know, the ICD has strong evidence through multiple randomized controlled trials in preventing sudden cardiac death in appropriate patients, but selecting who those patients are is an imperfect science, despite ample efforts at trying to identify independent risk factors for sudden cardiac death in susceptible patients. And so myocardial strain imaging has emerged as sort of a useful tool in a number of different clinical settings to provide incremental information beyond LV systolic function and LVEF, which has historically been one of the cornerstones in risk stratifying these types of patients. And so our study really employed this modality of feature tracking CMR to identify whether it may be an independent sort of predictor of adverse outcomes, and therefore maybe potentially an incorporable feature in determining who might be a candidate for an ICD implant. So just highlighting the methods here, we conducted a retrospective observational study at 2 tertiary care hospitals in Canada, both in Toronto, St. Michael's Hospital and Sunnybrook Health Sciences Center. The patients were enrolled between 2006 and 2017, and there were consecutive patients, all of whom ended up undergoing an ICD implant for either primary prevention, i.e. prevention of sudden death, or secondary prevention. They actually sustained malignant ventricular arrhythmia or out of hospital cardiac arrest and subsequently were resuscitated. And they were at least 18 years old, and all of them had a cardiac magnetic resonance imaging study performed prior to device implants. And we excluded patients who had known inherited arrhythmias, i.e. patients who were recognized to predominantly have channelopathies or inherited arrhythmias that were less involved in causing structural abnormalities, more isolated electrical problems, for whom we would not expect abnormalities in strain necessarily. And then we also excluded patients who had incomplete volumetric CNE images or insufficient quality for strain analysis to be performed, of which there were only about 37 patients total. And then we collected as much medical data as we could and demographic data as we could to go forward, and also their outcomes going forward in terms of appropriate ICD shocks and death. And appropriate ICD shocks defined as receiving shocks provided for a sustained ventricular arrhythmia, including VT or VF. And so our primary outcome was a composite outcome of either all-cause mortality or an appropriate ICD shock. We didn't include this other feature that defibrillators provide, which is the anti-tachycardia pacing, as a component of our primary outcome, because we know from previous studies and just conceptually that it's more dependent upon programming and therefore less standardized and less robust as an endpoint than an appropriate shock in terms of ICD treatment benefit. However, we did include ATP and ancillary analyses, which we'll get into. And patients were basically followed in, all of these patients were followed in a device clinic at least every 6-month intervals or less, based on either clinical or remote monitoring. And all of the events were then adjudicated subsequently. And death as quite a binary outcome were determined based on electronic chart review or autopsy records or hospital records. And then for CMR image processing, so basically the standard CMR images were performed on a 1.5T scanner, and fairly standard protocols for obtaining their CMR images. As I mentioned, these patients, when they had their CMR studies done for a variety of different reasons, they were not done at the time with the intent of having strain being performed. So we went back to perform strain analyses on their routinely obtained images. So the LV endocardial and epicardial borders were manually traced in long and short axes throughout the cardiac cycle. And peak systolic strain obviously is the maximum percentage change in length relative to the baseline length. And positive strain implies elongation, whereas negative strain implies shortening. And we obtain longitudinal strain based on long axis orientation, 2, 3, 4 chamber views, and circumferential and radial strain based on the short axis stacks. And we took 3 strain measurements, the standard measurements, so global longitudinal strain, circumferential strain, and global regional radial strain, pardon me. And as we know, strain expresses myocardial deformation at end systole as a percentage of the baseline of end diastole. So global longitudinal and circumferential strain, a more normal or more robust strain would be a more negative value, whereas for a global radial strain, it would be a positive value as an integer, more thickening, i.e. In terms of our statistical analyses, again, fairly standard sort of analyses of continuous and categorical variables with the Kruskal-Wallis-Mann-Whitney tests and chi-square Fisher's tests. We did Kaplan-Meier curves, which I'll show you shortly. Importantly, I just want to highlight for our multivariable analyses, we understood that strain parameters have a certain degree of collinearity with LVEF, and did not want to include both in a model if there was significant collinearity because of the risk of underestimating the impact of one of those variables. So we did assess for the degree of collinearity and found that GCS and GRS did have significant collinearity, and therefore only did models in our multivariable analyses that excluded LVEF together with these. However, GLS was felt to have a variance inflation factor less than 2.5 and was permitted to enter a model with LVEF. So we have a bunch of different multivariable models that I'll go through. And then we did subsequent interaction testing between ICD indication, whether there was ischemic or non-ischemic heart disease, and presence or absence of LGE. We also looked at sort of quantitative scar infarct, and then considered time to first ATP shock or death, because in the subsequent review of our paper, a number of concerns came up about excluding ATP, as I mentioned, even though it was a less robust endpoint. So in terms of our results, we had a total of 364 patients. Basically, mean age was 61 years old. About 80% or so were male. 61% implanted an ICD for primary prevention indication, and 57% had ischemic heart disease. And over 62 months, there were 21% with an appropriate ICD shock, and 18% died. So a total of 32% of our cohort reached the primary composite endpoint. So a reasonable sort of event number. And we found that there were clear correlations between strain parameters and LV volumes and mass and LVEF. I'll just scroll down to table 2 here. So, as expected, sort of positive correlations between a less negative GLS and GCS and greater volumes and greater mass, not unexpected. A sort of sicker, more dilated heart has reduced strain, and the converse for radial strain. And for LVEF, again, sort of a strong negative correlation and strong positive correlation, again, identifying that less strain corresponds to lower LVEF. And when we looked at actually, maybe I'll go next to the Kaplan-Meier curves. So these are I'm going to just reduce if you guys can see all 4 of them here, but basically these are the quartiles of our patients and their events going forward. On the y-axis is the appropriate ICD shocks or death. On the x-axis is time in days. And you can see that for global longitudinal strain, so the 4th quartile, in other words, the worst global longitudinal strain was associated with the highest rate of ICD shock or death. Similarly for GCS, and then the inverse for GRS, because it's a positive integer, so positive value. So the sort of greatest degree of ICD shocks or death occurred in the 1st quartile of GRS. So this is the unadjusted Kaplan-Meier analysis. And then in the multivariable analysis, we identified that GLS remained a significant independent predictor of the primary endpoints. I'm just trying to find, sorry, I know the paper outlines it, and I think it's down here. Perfect. Okay, so this is the outcomes in our adjusted models. We excluded LVEF here because of the collinearity potential for GCS and GRS. But you can see here for our primary outcome of appropriate ICD shock or all-cause mortality, there was a significant independent risk associated with GLS, GCS, and GRS. Again, in stratified analyses, some of these crossed unity, but again, this is likely because of relatively low events in each of the primary and secondary arms. And when we incorporated, I think this is higher up, when we incorporated LVEF into the model with GLS, we did find that there was still a significant independent predictive value of GLS for the primary endpoints. And then when we subsequently analyzed for primary versus secondary prevention, there was no significant interaction. When we adjusted for quantitative LGE by visual assessment, again, still significant interaction, significant predictive value. And GLS was also independently associated with the composite when we included ATP in addition to ICD shocks or death. And there was no significant interaction between GLS and either primary prevention, ischemic heart disease, or presence of LGE, as well as gender. So I know we're kind of coming up on 11:30. The discussion points really just highlight that GLS remained an independent predictor of appropriate ICD shocks and mortality, independent of LVEF, regardless of whether the ICD indication was primary or secondary. If the indication for the device occurred in a patient with ischemic heart disease or without, or in the presence of scar or infarct as defined by LGE. And, you know, I think just highlights that, as mentioned initially, the utility of LVEF for predicting sudden cardiac death is well recognized, but imperfect. And so this study kind of just highlights a potential utility of really a modality that doesn't require any additional images to be acquired, any specific protocoling for your CMR images, and can really, I think, if found to be useful, provide even an additional reason for all patients for whom clinicians are on the fence about whether they warrant a defibrillator for risk stratification, just to have a CMR to provide all sorts of information, not only scar quantification and tissue characterization, myocardial viability, but also now strain, in addition to accurate LVEF assessment. So I'll stop there and just invite questions, as well as you know, any comments from my co-authors who I know are also on the call.
Thank you very much, Nigel, for the fantastic presentation. So, of course, Andrew, you're invited to comment or to add where you deem helpful. Congratulations, as for Magnus, for a great study that addresses this very important question. And to me, the question of ICD implantation and the criteria we use has really not been satisfactory, and that's true for the entire cardiology field. And just, I think, another paper was published trying to combine various markers. And while I totally agree that we should not always try to find that one single marker that says it all, does it all, we have to combine things. That, like a clinician, we have also within imaging, we have to probably combine some things. But it looks like from both papers that the global longitudinal strain is a very, very helpful marker. So there's a question, any significant inter or intra-observer variability in the strain parameters? So that's very important. How robust are these measurements? And I would maybe even add the reliability. Are there certain regions or segments that you found to not be very helpful because there's a lot of variability or whatever? But you also use 2, 3, and 4 chamber views. So can you comment on that? So intra-observer variability.
Yeah, certainly. So we did some analyses to identify what the intra-observer variability was, and it was excellent here. I've sort of highlighted in blue here. I don't know if you guys can see on the screen that I'm sharing. So we had sort of you know, over 90, sort of 95% agreements with measurements. You know, we use one software modality, so I can't comment upon, if you know, different software modalities, what the variability would be across different vendors. I do imagine there would be some difference, but if you're using the same vendor, you know, across multiple studies, there probably would be fairly consistent results.
No, thank you very much. And also, I want to point to the comment from Marcus. Probably we need to combine cohorts from several trials to see how a model of ejection fraction, strain, border zone, LGE, etc., can predict ICD therapy and death. I agree. And now the additional tools we have is there are some efforts like you can share. So EU can share networks, transnational networks that allow to share large data. And then we have machine learning that could help in finding the best combination between various markers. So there's a lot of exciting stuff to come. And I think these papers add very important information for that. So thank you so much, Marcus and Nigel, both for the excellent presentation of these really very, very important and interesting papers. So Nigel, if you could just unshare your screen, then I would hand over to the next Journal Club's host, Bettina Bessler, who's calling in from Switzerland, I think.
No, Würzburg, actually.
Oh, sorry. My God, it has been a while.
But this
and
is so
quickly.
No problem. I
okay,
hope
so
I'll
from
stay
Würzburg,
here
I should
for a
know.
while. Yeah, okay. So thanks for the great presentations. I really enjoyed them. And the next CMR Journal Club is actually on the same or similar topic, strain again, but now not strain of the ventricle, but of the left atrium, which is also a very interesting topic, I think. And we will have two papers, one a bit more methodological paper on reproducibility, which comes from the group of Anvesha Singh from Leicester, which looks at the reproducibility of left atrial strain parameters and function, actually, on CMR. And the other paper comes from Amsterdam and will be presented by Luke Hopman. And this is a paper which looks at the left atrial reservoir and conduit function by strain in atrial fibrillation and in patients who have extensive left atrial fibrosis. So two interesting papers. I'm looking forward. We'll meet again on January 5th, so quickly after the new year. And with that, I leave it like this and wish you a very happy holiday season and hand over to Matthias back again.
Yeah. No, thank you. Thank you very much, Bettina. So I hope to see you all again. And repeating what Bettina said, I wish all of you all the best for the holiday season, or as we in Germany say, the days between years. And I hope to see you all back on January 5, and also all the best for the new upcoming year. Take care. Bye-bye.